My role as a medical oncologist here at this session is to discuss the castration-resistant prostate cancer and specifically the sequencing of the therapy in this setting. As you know, and we talked the whole day about early stages of prostate cancer, about castration-naive prostate cancer, about biochemical progression. These are all stages which can be more or less effectively treated, sometimes even curative, most cases curatively, luckily. But at the end, we are looking at the progressive disease with little options and almost always one or the other kind of recurrence. So first, we have to take a step back and look at what are our definitions of castration-naive and castration-resistant prostate cancer. This is a very simplistic diagram, and it shows you how we think about prostate cancer. We have the castration-naive stage, and since over 70 years ago, where Mr. Huggins, as you heard, developed the androgen deprivation therapy, we treat the castration-naive patients with or without metastases with androgen deprivation therapy. I think, and as you heard in the previous talk, and I will repeat some of the topics very shortly, this might not be relevant today. Results of the Charted trial and of the Stampede trial and of the Latitude trial showed us that many of the drugs which we used in the castration-resistant setting may be as effective, if not more effective, in the castration-naive setting. So you would probably have some intermingling, or you have to remove the boundary of castration-resistant and castration-naive. We will use most of the drugs, I'm sure, from the castration resistance earlier and earlier, and they will show maybe such very excellent survival benefits as abiraterone and docetaxel showed recently. So what does it mean? How do we sequence the therapies in the castration-resistant setting if we have maybe the same therapy in the castration-naive setting already given? So these thoughts have to enter our practice, because we have to think hard what we do in the castration-naive setting, what we do early on, because this will influence the resistance, the behavior, the metastatic potential of the disease at later stages. So, and maybe we even, there's no data for that, we even might have some influence of these drugs in non-metastatic states. So you see in the slide, obviously, the landscape of prostate cancer treatment in 2017 is getting crowded. It's like a jungle. And I will try to clear the path for some of the therapies which might be efficient and effective to show you a way through this jungle. So let's get into media res. There have been several trials performed in castration-resistant prostate cancer which address the question which therapies should be given first, which second, which third. These are all small, retrospective, mostly studies done at one institution only, which means that their results, however convincing, have to be taken with a pinch of salt. If you look at the sequencing of abiraterone after enzalutamide and docetaxel as a third-line therapy in castration-resistant prostate cancer, you see that the PSA response rate drops to something about 8% or 3%. If you compare it to the 30% in the abiraterone in the study which led to abiraterone approval post-docetaxel in the CO301, this seems really, really low. The same can be said to enzalutamide. Again, small retrospective single institutional studies performed in the last 5 to 7 years. And they all find similar results. PSA response rates, median overall survival, median PFS drop with the previous use of other hormonal therapies. A firm study had a PSA response of 54%. This could not be recapitulated in any of these small retrospective studies. Again, these are, what about vice versa comparisons? How do chemotherapies perform after you've given novel hormonal agents? Several studies, again, small and retrospective, compared this sequence. Docetaxel after abiraterone. And you see the data from the TEXT 327 trials, you see the data from the control arm of the Venice study, and not all of these studies come to the same conclusion. Sometimes you see nice PSA declines, but really the median overall survival is not reached in any of these retrospective analyses. As I told you, most of these studies were done in several institutions. So what if we look at one single cohort and at one institution? I call it the Johns Hopkins experience, because that might give us at least a homogeneous approach to the therapy of these patients, because they are treated at the same institution, same physicians, same staff, same therapeutic algorithms. So they performed a number of retrospective analyses to approach these questions. So first of all, how does enzalutamide compare with docetaxel after abiraterone? Here they find no difference. So that's good news. Again, if they look at a different cohort and just compare the switch of docetaxel to abiraterone or abiraterone to docetaxel, they find no difference. Although if you look at these two cohorts, there might be a difference. Here you have a median PFS of the ABIDOG of 4.4. You have not the same patients, but the same cohort from which these patients were taken at the same hospital. And here you have the same sequence of therapy, but the median PFS was 10.4 months. So these results might not really tell us how to sequence therapies. And the last result, which had some significant results, was that they concluded that enzalutamide given after abiraterone might have some effect on PFS, although not on the overall survival. So last set of slides I will show you to the sequencing of these therapies concerns cabazitaxel, the second chemotherapy which is approved as a second-line treatment after docetaxel. There has been, again, several sequences done, and some of them show, so two independent trials, show that sequencing of cabazitaxel directly after docetaxel might be more effective than when a novel hormonal agent is put in between. So there are two studies. One shows the effect on PFS, one shows the effect on OS, overall survival, where the sequencing of novel hormonal agent, docetaxel, cabazitaxel, or docetaxel, cabazitaxel, and then a novel hormonal agent is a little bit more effective than when you put the novel hormonal agent in between. Again, retrospective, single institutional observations. I have to conclude after these 5 minutes or 7 minutes that I cannot give you the answer. I cannot give you a confident, evidence-backed answer of which sequence is the best. I might give you hints. So what we agreed on, and that these are consensus statements from the APCCC and so on, that probably we have to look at the patient. We have to individualize the therapy according to the patient. What is his status? How does he tolerate chemotherapy? Has he an urgent need for rapid symptom relief? So for patients who have a large symptomatic burden, maybe chemotherapy might be the right choice as a first-line therapy. For patients who have a low symptomatic burden and might not be willing to undergo the side effects of chemotherapy, the novel hormonal agents might be right. Again, the duration of prior ADT or the duration of response under the prior ADT might also have a role. Patients who have a short duration of the androgen deprivation therapy, less than 1 year, who progress after 12 months, have some resistance to the novel hormonal agents. So for them, maybe docetaxel would be their choice for first-line therapy. For cabazitaxel, as I showed you, maybe the sequencing, again based on retrospective analysis of docetaxel and cabazitaxel right after each other, might be the right approach, and not put the novel hormonal agents in between. Nevertheless, we tried in the last 5 to 6, 7 years to address these issues, to find the right sequence, but I will show you that probably, despite, it's not because of the lack of trying that I cannot give you the answer. It's purely the combinatorial difficulty of addressing all possible combinations. So these are the combinations of 5 drugs which we have in castration-resistant prostate cancer, and all the different permutations. So we won't be, I can tell you quite confidently that we won't be able to tell you, based on prospective clinical trials, or even on large retrospective analyses, which of these 60 combinations is right for you. So we have to think back. We have to think back. There's been talk about predicted biomarkers, and of course, that might be the way to go. And I didn't even address the possibilities of combinations. So these are monotherapies. And there are studies underway where you combine the approved agents, or even combine them with novel agents here in red. So these are all studies currently ongoing, where you can basically multiply the number of possible combinations and sequencings. So, but we still know that if you look at only the novel hormonal agents, that there are primary resistances, and 1/3, 1/4 to 1/3 of patients won't respond to these therapies. Again, all these trials which I have shown you concluded that we need good predictive biomarkers for these therapies. And that's the reason why the androgen receptor variant 7, splicing variant of the androgen receptor, which is, can be detected in the circulating tumor cells, was hailed as the biomarker to decide whether to assign patients with castration-resistant prostate cancer to novel hormonal agents, where they don't respond if they have this variant, or to taxanes, where it doesn't matter. It's still not here, so we are still not able to use it in clinical practice. The assays are being developed. They will be testing prostate prospectively. There's no prospective validation of this test, but I think that this might be the start. Shouldn't we think a little bit broader? I mean, we have the data. We have a lot of data. We have the last 6, 7 years gave us millions of data of genetic, epigenetic, protein-based, metabolic data on prostate cancer. Can we use them in some way to actually choose patients or assign patients to the right therapies? There are gene panels, or panels of genes which were tested retrospectively, which might give you some prognostic information on which patient might progress on which therapy, but they were not tested prospectively. And although these or similar oncotype TX for breast cancer have been validated prospectively in breast cancer, maybe we still don't have the data from prostate cancer. So maybe we are waiting for something which will never come. And as we learned recently through this data, we are treating a very, very heterogeneous disease. Gero Kramer told you about the possible subgroups and how they might respond differently to different therapies. And you can see them here, you can define them genetically, but you see on the right side that even within these subgroups, each patient is different. Each patient has a different set of genetic, epigenetic alterations. So we are all individuals. We all have the same histological cancer, but we have to treat probably each individual differently. Another issue which makes this more complex is that cancer is not a static disease. It evolves. It evolves under chemotherapy. It evolves under hormone therapy. Most of the patients have their disease since many, many years. And the disease which was there at the beginning might not be the disease which is there now. So how do we address it? How can we find what is the right way? One study which was published recently, 1 year ago, has shown that there is a pragmatical way, there is a kind of a path which may lead us to the rational design of novel therapies in castration-resistant prostate cancer. This regards germline or alterations in the DNA repair genes. Another study showed that up to 12% of prostate cancer patients have some mutations or alterations in the DNA repair genes. And we know that DNA repair patients in breast cancer or in ovarian cancer which have these alterations respond very well to PARP inhibition, to a drug, to a single drug which is inhibiting another pathway of DNA repair so that the cell cannot repair itself and it dies. This study by Matteo et al. Showed that 1/3 of prostate cancer patients have an alteration in a DNA repair gene. And most of them, 80% of them, respond to single agent olaparib. So maybe that's the reason why we should focus on these smaller trials, find predictive markers, and assign patients to clinical trials more rapidly. And I cannot, because I'm a medical oncologist, I cannot leave here just to mention what happened in oncology in the past years, and that is the realm of the immunotherapy. Me myself witnessed the evolution of immunotherapy from a disregarded hypothesis to state-of-the-art therapy. And although we know that there are some markers of response to immunotherapy, this is hypermutation or mismatch repair deficiency, and prostate cancer doesn't fit into that category. And we even have clinical data on ipilimumab in prostate cancer which did not show survival benefit, overall survival benefit, despite showing better PFS and some dissociation of the Kaplan-Meier curves. There is reason for hope. In March of this year, there's a very well-published study in Nature which showed that in mouse model of prostate cancer, of castration-resistant prostate cancer, combination of immune checkpoint blockade with small tyrosine kinase inhibitors, either cabozantinib or BEZ-235, could effectively be synergistic and eliminate tumors in these mice. So maybe we just need to find rational combinations to introduce immunotherapy even into prostate cancer, and the trials are ongoing. But I mentioned that there is another way. There is a way to find these predictive markers, and I think one approach might be within registry trials, within trials of personalized medicine or precision oncology, whatever you name it. There's been a lot of discussion whether that's the right approach in the recent literature, but I think it might be the way to go. It is very simple from how it's structured. You take a biopsy, or you assess the tumor genetically, epigenetically. You might even do some ex vivo testing for sensitivity. You treat the patient, and after progression, or at the time of progression, you do the same again. And you learn. That's what I want you to. You learn from this data. So you have to include these patients in clinical trials, which gather the clinical data, include them in large databases, in large in large prospectively based databases, which have to be probably gathered internationally, and that's why you are here, because that's an international issue. And what we need, what we had in 2007, just to remind you, is docetaxel. What we have now, 10 years later, is that we can probably select patients according to some criteria to the one or the other therapy. But what we need now is clinical trials, and clinical trials where we can first rapidly adapt the findings of biomedical research and translate them into clinical practice, either immunotherapy or PARP inhibitors. We have to perform controlled and documented use of these novel therapies. We should not leave this in the hands of general practitioners or regional centers. We should pull the patients into large centers and document them well. because this heterogeneity of prostate cancer can only be addressed with a large number of patients, and these studies have to be done internationally, trans-institutionally, and they need time, money, dedicated physicians, and you, forward-thinking patients. And I hope that in 10 years from now, we might have some kind of personalized therapy for these patients which brings actual survival benefits. Thank you very much.